This morning we have one of our chief residents, Dr. Carlo Martinez, who will be talking to us this morning about achalasia. Dr. Martinez grew up in San Antonio. After graduating from high school, joined the U.S. Army and was a medic. After that, he returned to San Antonio and is a graduate of UTSA. Then he did his medical school at Washington University in St. Louis, and then back here for his general surgery residency. And he is matched with this program next year for cardiothoracic surgery. And we're pleased to have you here this morning, Carlo.
Right, thank you. Good morning. Today I'll present achalasia. And achalasia is a chronic, incurable disease that is characterized by the incomplete relaxation of the lower esophageal sphincter, or the LES, and aperistolysis of the esophageal body. I will describe the history, pathophysiology, and etiology of achalasia, as well as patient presentation, the current diagnostic modalities, and the current or the various treatments for achalasia. We'll end with a discussion of a current study comparing the main treatment modalities and a brief description of future therapies. In 1679, Sir Thomas Willis of Britain had a patient who was unable to pass solid food from the esophagus to the stomach. He devised a treatment for this disease, which consisted of a whalebone with an attached sponge that the patient would use to push the bolus of food down from his esophagus to the stomach. And using this method, he was able to live for 15 years. Von Michelitz also had several patients with the similar disease, and he named the phenomenon cardiospasm. He also described the performance of a lower esophageal dilation via a gastrotomy in 1904. In 1913, Heller was able to perform an anterior and posterior esophagomyotomy, which extended 2 centimeters onto the stomach for the treatment of cardiospasm. And then in 1924, Hirsch proposed that the esophageal dilation seen in these patients was due to the absence of physiologic relaxation of the LES rather than an abnormal contraction. He also changed the name from cardiospasm to achalasia, or failure to relax. And then shortly thereafter, Lundrum had published a autopsy report on 13 patients with achalasia, and he was able to demonstrate that all of these patients had an intact vagus nerve, and there was a loss of the ganglion cells within the myenteric plexus. This was followed in 1962 by Dor describing the anterior partial fundoplication as an anti-reflux procedure for patients who had undergone the Heller myotomy, and then in 63, Toupé described the posterior partial fundoplication as an anti-reflux operation to make up for the lack of crural closure. So the pathophysiology of achalasia is linked to the destruction of the ganglion cells that results in impairment of LES relaxation. There's also an associated inflammatory response with this disease. These are H&E stains of the myenteric plexus, and the normal myenteric plexus demonstrates multiple ganglion cells with minimal lymphocytic infiltration. With increasing lymphocytic infiltration, we see a gradual loss of the ganglion cells. So some are still present in image B, but by C and definitely by D, there's a complete absence of the ganglion cells. This inflammatory response may implicate an autoimmune, viral, or chronic degenerative process. So the etiology of achalasia is predominantly idiopathic, with either viral or autoimmune processes being more commonly accepted. There is a group of patients with Algrove syndrome, or the AAA syndrome, which stands for achalasia, alacrima, or lack of tear ducts, and ACTH-resistant adrenal insufficiency. This is due to an autosomal recessive mutation of chromosome 12, and patients tend to present at a very young age. It's important to differentiate achalasia from other esophageal diseases. So pseudoachalasia is a functional distal esophageal obstruction that may mimic primary achalasia. It is seen in patients with obstructing GE junction tumors and Chagas disease. Also, functional obstruction of the LES may occur with some fundoplication procedures and gastric banding procedures. In addition, these topics here do come up on the ABSCITE for the residents, and it's important to differentiate achalasia from esophageal motility disorders such as scleroderma, nutcracker esophagus, and diffuse esophageal spasms, as well as from esophageal diverticula. So nearly all patients with achalasia will present with dysphagia of solid foods, as well as regurgitation of undigested foods and avoidance of certain foods that are difficult to swallow. About 1/3 of the patients will start having some weight loss, and anywhere between half to or a quarter to half of the patients will describe a chest pain or heartburn that is relieved with regurgitation of the undigested food. Additionally, with a good history, aspiration or aspiration pneumonia can be elicited from these patients. So the diagnosis of the patients. When a patient presents with suspected achalasia, a barium swallow should be the first study performed, as up to 95% of these patients will have can be diagnosed with this. A positive study has an aperistaltic esophagus that is observed to taper down to in the distal esophagus to the characteristic bird's beak at the level of the esophageal hiatus. This is in contrast to diffuse esophageal spasm, which has its characteristic corkscrew esophagus, and this results from the spastic contraction of the esophageal muscles that are usually in a helical array. It's important to differentiate achalasia from diffuse esophageal spasm because DES requires a different treatment, whereas achalasia requires a limited myotomy. DES requires a long myotomy starting from the stomach up towards the level of the aortic arch. After a barium swallow has been performed, the esophageal endoscopy is used to evaluate the patient for other causes of esophageal obstruction. Here's a barium esophagram, which shows the dilated tortuous esophagus that again tapers down to the bird's beak right here. The endoscopy also demonstrates this dilated tortuous esophagus. With achalasia, the patients will have a puckered LES that will provide resistance against the endoscope, and that will kind of give you a popping sensation once you're able to go through the LES into the stomach. Oftentimes, the endoscopic findings of achalasia will include the presence of retained food particles and fluid. And as a previous slide demonstrated, the mucosa of patients with achalasia will usually be normal. However, with stasis of fluid, food, and pills, the patients can develop friability, erosions, or candida esophagitis. So esophageal manometry is the key test for the diagnosis of achalasia. And here's a schematic of representation of several configurations of the esophageal monometric assemblies. A polygraph is generated from the pressure sensors that are lined along this along the manometry, and they'll have various different sensors. And what's new now is this 21-channel high-resolution manometry, and we'll discuss that shortly. However, these are the idealized polygraph results from manometry of various esophageal disorders. As you can see, the pressure readings are identified by location of the pressure sensors along the esophagus and are displayed according to time. The mobility of the esophageal body is characterized by peristalsis, which is contractions that are propagated down the esophagus at a rate of 2 to 4 centimeters per second. If we look at the normal esophagus, the upper esophageal sphincter and the lower esophageal sphincter usually appear as high pressure zones, and in swallowing is signaled by contraction of the pharyngeal apparatus and then immediate relaxation of the upper esophageal sphincter. Then we have a contraction that's propagated down the entire length of the esophagus, and with a resultant relaxation of the lower esophageal sphincter. And this is what should be seen in normal swallowing. With scleroderma, the replacement of the smooth muscle of the esophagus by fibrosis results in decreased contractions or reduced contractions of the esophageal body and a hypotension of the lower esophageal sphincter. And this here is what differentiates scleroderma from achalasia, is this hypotension of the LES. In achalasia, again, we show that there are reduced contractions along the esophageal body and a hypertensive LES, or an LES that fails to relax with swallowing. And this is these are the diagnostic features in manometry that are looked for: aperistalsis of the esophagus and failure of the LES to relax. With diffuse esophageal spasm, we have a simultaneous onset of high pressure, repetitive, prolonged contractions. And then this is all in contrast to the motor disorders of the upper esophagus, where we have hypotension of the pharynx apparatus, or decreased contractions of the pharynx apparatus, an upper esophageal sphincter that is also weak, and then normal esophageal contractions with normal LES function. So referring to the high-definition manometry. So with the advent of placing additional sensors along the manometry, they've been able to develop what's called the esophageal topography. And again, the information is still presented along the length of the esophagus with time. And in place of the polygraph pressure readings that we normally see, we are presented with color-coded pressure readings. So again, in a normal esophagus, the swallowing is detected in the pharyngeal channel, and this is followed by upper esophageal sphincter relaxation, and then propagation of contraction along the esophageal body, and then relaxation of the lower esophageal sphincter. Additional information can be obtained from this diagnostic modality. For example, if you notice this low pressure zone right here, this demarcates the transition from the upper esophagus that has striated muscle to the lower or distal esophagus, which has smooth muscle. So the esophageal topography of achalasia demonstrates, again, this minimal pressure activity within the esophageal lumen and the non-relaxing LES. And then here, the esophageal topography of nutcracker esophagus demonstrates an initial normal pattern peristalsis that is followed by high pressure contractions and prolonged repetitive contractions of the esophageal body as well as the LES. And these will correlate with the chest pain that the patients describe with this phenomenon. Again, diffuse esophageal spasm, there are these simultaneous onset high pressure repetitive contractions. All right, so the treatment of achalasia. So the endoscopic treatment of achalasia includes injection of Botox. So Botox works by inhibiting the release of acetylcholine in muscle synapses, which inhibits muscle contraction and results in flaccid paralysis. The first use of Botox was described in '93, and multiple studies have been undertaken evaluating the efficacy of Botox for the treatment of achalasia. The treatment is initially effective with 80 to 90% of the patients describing relief of symptoms. However, by 1 year, many of them are no longer asymptomatic. This, at times, will be combined with pneumatic dilation to increase or to prolong the efficacy of Botox. And however, that also comes with fairly mixed results, with pneumatic dilation and Botox equaling pneumatic dilation by itself. So the goal of pneumatic dilation is to disrupt the muscle fibers of the LES without causing full thickness perforation, thereby facilitating the passage of food from the esophagus into the stomach. This barium swallow of the patient with achalasia again demonstrates the classic bird's beak of the LES, and here the balloon is passed through the LES, and dilation reveals the balloon waist of the LES. And this balloon waist becomes important in several studies of the efficacy of pneumatic dilation. And the post-dilation barium swallow demonstrates passage of barium into the stomach. So initial studies reported 75 to 85% of patients with excellent to good results. However, at best, some of these studies had 3-year follow-up, but the majority of them had less than 2-year follow-up in these patients, and multiple dilations were performed on patients with achalasia. The overall complication rate is 11%, and the perforation rate can be anywhere between 1 to 3%. So to study the long-term outcome of pneumatic dilation in achalasia, Husselman et al. Designed a prospective study where they got newly diagnosed patients with achalasia, performed dilation, and followed them for a period of 10 years. So 209 patients were, 227 patients initially were enrolled, but they were only able to get follow-up on 209 patients. And all these patients were treated initially with a consecutive esophageal dilations. So what they would do is they would bring the patients into the hospital, and on the first day dilate them with a 3-centimeter balloon, and then record manometry. If they were able to get the LES pressure down below 15 millimeters of mercury, then that patient was done. And less than about 25% of patients, this was possible. The majority of the patients remained in the hospital for 2 days, where the following day they would get redilated with a 3.5 centimeter balloon. And again, manometry post-procedure. If it was less than 15 millimeters of mercury, they were done and they were allowed to go home. 1/3 of these patients ended up staying in the hospital for 3 days, which is almost about as long as they would stay for a lap Heller. They would stay in the hospital for 3 days and get dilated with a 4-centimeter balloon, and then they were allowed to go home. As we see, using this protocol, they were able to obtain long-term remission in 2/3 of their patients. 1/3 ended up developing recurrence. Of these, 10 patients underwent Botox injection, 13 patients underwent myotomy, and then 49 patients underwent repeat dilation, with the majority of those, again, being able to obtain long-term remission. So in all, if you include these with the initial good response and these with a good response after repeat dilation, about 70% of the patients obtained a good symptomatic relief from this. Again, the drawbacks of this were 1/3 of the patients had to stay in the hospital for 3 days, and the perforation rate was less than 3%. None of the patients requiring operative repair. They were all treated non-operatively. However, from this data, they were able to look at, again, this is the percent of patients in remission per time, and we see that with first dilation, there's just a continued decrease of these patients who remain in remission. And then even with repeat dilation, you get initial good response, but it slowly continues to drift down. And when they looked at the characteristics of their patients who either had a good response to pneumatic dilation or a poor response to pneumatic dilation, they saw that the two main characteristics were age. So patients less than 40 or less than 41 tended to not be successful. And then the post-treatment LES pressure. Again, their goal was to try to get a LES pressure less than 15 millimeters of mercury. And those that remained with an elevated LES pressure at 17.7 ended up failing. So here, when they looked at the patients, they looked at their patients who required a retreatment and divided them out per age. Again, here was their cutoff, about 41. About 41 is where they see that the majority of the patients will end up failing and require additional treatment for achalasia. And then as well as the final LES pressure. So their pressure right here at around, it was around 17, but patients who were less than 12 ended up faring better than patients who were higher than 17 millimeters of mercury. So by the time they published their long-term outcome of pneumatic dilation, other studies or other groups had actually published their retrospective results on the long-term outcome of pneumatic dilation. And again, they were all able to demonstrate that over time, the success rate of pneumatic dilation for achalasia continues to decrease. So the initial 75 to 85% success rate seen in patients gradually decreases to about 60% at 5 to 10 years, and then 40% at greater than 15 years. So they started looking at the predictors of failure for pneumatic dilation. And here, and these were all prospective studies. Here, Eckert's group, they were able to see that patients, again, younger than 40 years of age, ended up having a low probability of success rate. So if patients greater than 40, about greater than 55% of these patients ended up having a successful treatment at 10 years, whereas less than 25% had a successful treatment at 10 years, as well as LES pressure. And this basically confirmed the results that Husselman and his group saw. And then this other group here from the Netherlands were able to demonstrate that age and LES pressure were also factors, but they also noted these guys actually had a very nice study where they recorded everything, not only how the patient responded, but also if there was a obliteration of the balloon's waist during the pneumatic dilation. And then they followed these patients out at 3 months, 6 months, 9 months, 12 months, and then 2 months thereafter for a total of 10 years. And with each follow-up, they would repeat an esophagogram, a manometry, and endoscopy. And they were able to demonstrate that incomplete obliteration of the balloon's waist during the pneumatic dilation was also a risk factor for failure of pneumatic dilation. And so now all these groups recommend that anytime they have patients with achalasia that are less than 40, that if pneumatic dilation is performed and they have LES pressures that are greater than anywhere between 10 to 15 millimeters of mercury after procedure, and if there's incomplete obliteration of the balloon's waist, that these patients should be referred for early operative intervention. So they should not be followed out long-term and receive serial dilation. So this brings us to the Heller myotomy, the laparoscopic Heller myotomy. Again, Heller first performed the procedure in 1913, and in 1991, the laparoscopic Heller myotomy was described. And since then, multiple studies with large patient group have been published, and that demonstrate the success rate of the laparoscopic Heller myotomy. The initial success rate is anywhere between 90 to 92%. And those patients that do fail, especially if it's early failure, this is predominantly due to an incomplete myotomy at the initial surgery. So these patients will go back and have a redo operation, as well as, or they can be rescued with pneumatic dilation. And with this brings the success rate up to about 95, 97%. There's about a 2 to 12% complication of the procedure, and a 1% conversion rate is described. The myotomy is described as anywhere between 4 to 6 centimeters on the esophagus and 1 to 2 centimeters on the stomach. And so then we end up having several debates as far as the laparoscopic Heller. So the first one is the length of the myotomy. Does the length, trying to figure out if the length matters and what length that should be is very difficult. As you can see, there are just multiple studies that have been done that look at different lengths of the myotomy along the esophagus and along the stomach. And this kind of just represents how they fall. So more recently, a concern by one of the groups in Montreal was they used to perform a long myotomy of 8 centimeters onto the esophagus with 2 centimeters onto the stomach. However, patients that they'd seen like 15 years after the myotomy, they do endoscopy on them. They noticed that some of these patients ended up having diverticularization of the esophageal mucosa where the myotomy was performed. And they contributed this to the very long esophageal myotomy. So now they describe a short Heller myotomy. So it's 4 centimeters on the esophageal, on the esophagus, and still the 2 centimeters on the stomach. Their initial results on these patients is fairly comparable to their long myotomy in that the patients have very good relief of symptoms. However, it's very early results. It's about 2-year results, and it remains to be seen if these patients will remain asymptomatic. So at least for the residents, for us, it's a little easier than having to refer to the literature, where we can just look at our reference books to figure out what length of myotomy needs to be performed. So if you look at Soper's book, The Mastery of Surgery and Laparoscopic, or The Mastery of Endoscopic and Laparoscopic Surgery, you see that chapter is actually written by Patty from UCSF, and who's actually has this publication. And he recommends a 5 centimeter esophageal myotomy, and at least in the book, anywhere between 2 to 2.5 myotomy on the stomach. And then Chasen's book actually is by Ellis's group, which is right here. And then there, he states that the myotomy should be anywhere between 5 to 7 centimeters, same as his publications, and that the myotomy on the stomach should not exceed more than 1 centimeter. And then if you look at Mastery of Surgery, they describe a 5 to 6 centimeter myotomy on the esophagus with anywhere between a 0.5 to 1 centimeter myotomy on the stomach. And then the Cameron's it's a 6 centimeter myotomy on the esophagus with 1 to 2 centimeters on the stomach. So still, right there, there appears to be no consensus within the reference books for us. So another area for debate was the wrap, or at least initial debate was the wrap. Against the initial Heller myotomy was performed without a wrap, and in '62. Dor described his anterior partial fundoplication for the treatment for an anti-reflux procedure for patients who had undergone Hellers. And at least in this randomized study that compares a Heller myotomy to a Heller myotomy with Dor fundoplication, they were able to demonstrate that the postoperative reflux was decreased from 48% down to 9% in those patients who did receive the fundoplication, which in this case was a Dor fundoplication. And then when a randomized study was performed comparing the laparoscopic Heller myotomy with either a Dor fundoplication or a Nissen fundoplication, they were able to demonstrate that both of these procedures have equal success rate for achalasia, and they both decrease postoperative reflux similarly. The main difference is that with Nissen, 15% of the patients had postoperative dysphagia, and 3% had postoperative dysphagia with Dor. So Dor fundoplication is also the preferred method of treating esophageal perforation during the myotomy. And so at least right now, the laparoscopic Heller myotomy with a Dor fundoplication is the more commonly performed procedure for achalasia. So then how is this performed? Here laparoscopically, we have our ports, we have our working ports, and then scope as well as retractor. With the Dor fundoplication, the initial stitch incorporates the fundus of the stomach with the esophageal wall and the left crus. And then the two additional stitches, so there tend to be 3 stitches on this side. The additional stitches just include the fundus of the stomach with the esophageal wall. And then when we wrap this around, we get fundus of the stomach, esophageal wall, and then the right crus. And then the subsequent stitches just get the fundus and the esophageal wall right here. So 2 stitches that incorporate the crus, and then 2 stitches that just incorporate the fundus and the esophageal wall on either side. And then there are additional 2 stitches that basically tag the fundus onto the to the diaphragm. And then here's the posterior partial fundoplication. Again, the fundus is wrapped around the esophagus, and then it's just attached to the esophageal wall, maintaining the myotomy open. So then, other areas of debate now are thoracoscopic versus laparoscopic Heller myotomies. So the additional Heller was performed through a thoracotomy, and that through the thoracotomy it was a little difficult to get a good myotomy down the stomach, as well as this procedure carried the morbidity that's associated with a thoracotomy. And so in '91, when the laparoscopic Heller myotomy was described, many of the surgeons started performing the lap Heller. But now, with the advent of minimally invasive thoracic surgery, the thoracoscopic Heller myotomy has been compared to the laparoscopic Heller myotomy. And at least in these studies, none of these are randomized. But these studies demonstrate that there's equally effective results in reduction of symptoms of achalasia with either procedure. And the postoperative morbidity is similar. The main differences are that the lap Heller myotomy has a shorter hospital stay, on the average of 1 day, and the lap Heller myotomy has a shorter operative time. So it takes about 100 minutes to perform a thoracoscopic Heller myotomy versus about 90 minutes to perform a laparoscopic Heller myotomy. Additionally, with the thoracoscopic Heller myotomy, you need to perform a single lung ventilation, and so that also adds time to the procedure. And then what to do with patients with megaesophagus. Many of the additional studies that looked at laparoscopic Heller myotomy in achalasia looked at patients with esophageal dilation of less than 4 centimeters. With this group here, they were able to start looking at patients with larger esophageal dilations, greater than 6 centimeters, and they found that these patients still have very good results with laparoscopic Heller myotomy. Initially, many of these patients would be referred just to esophagectomy. And then there's this other paper here that they were able to describe the laparoscopic Heller myotomy in patients whose esophagus averaged about 11 centimeters in diameter, so patients with megaesophagus. And in all these patients, actually this only had 4 patients. So in these 4 patients, they described excellent results in all of them, and with neither one of them requiring an esophagectomy. There were a couple of patients up here that had a very sigmoid esophagus that had poor response to lap Heller myotomy, and either redo operation or pneumatic dilation was unable to relieve their symptoms. And so these patients did eventually end up undergoing an esophagectomy. So here they recommend that the first procedure for patients with a enlarged esophagus, a dilated, tortuous esophagus with achalasia, first procedure should be a laparoscopic Heller myotomy with fundoplication. And if they are unsuccessful, then an esophagectomy can be performed for persistent symptoms. So this brings me to the more recent trial that was published in New England Journal of Medicine that compared pneumatic dilation versus laparoscopic Heller myotomy with fundoplication for idiopathic achalasia. So it's by the European Achalasia trial, and many of these they're from several European nations. So 214 patients newly diagnosed with achalasia were randomized to receive either pneumatic dilation or laparoscopic Heller myotomy with fundoplication. This was the time period where they were accepting patients, and it was a multi-hospital, multi-nation study. Here were the eligibility criteria, and then the exclusion criteria where the patients had to be poor. Patients could not be poor surgical candidates, because then that would limit their randomization, as well as they list previous achalasia treatment. However, if the patients underwent treatment either with the bougie dilators, they considered that okay, and if they underwent pneumatic dilation with balloons that were less than 2 centimeters in diameter, they considered that okay as well. Those patients were still accepted. But they did exclude patients with enlarged esophagus. And then the protocols for these, the pneumatic dilation. Initially, they were dilating the patients with a 3.5 centimeter balloon. However, within the first 13 patients that were dilated with this protocol, they had 4 perforations, half of which were treated non-operatively, the other half required an operation. So this is a very, very high rate of perforation with pneumatic dilation compared to previous studies. So they went back and they amended the protocol, and they followed what the people in the Netherlands had done. So they would admit the patients, and the patients would undergo a series of balloon dilatation. So the first series was with a 3 centimeter balloon, and then followed with a 3.5 centimeter balloon. And if the patients were still symptomatic at 4 weeks, then they would have a second series of dilations with a 4 centimeter balloon. And if at that time the patients were still symptomatic, they were considered a treatment failure. During the follow-up, patients who had recurrent symptoms within 2 years were considered treatment failures, and then those that had symptoms greater than 2 years were allowed a third series of dilations with a 3.5 centimeter and 4 centimeter balloon, and then if they recurred after that, then they were considered treatment failures. With the lap Heller myotomy, with Dor Fundoplication, the myotomy was performed greater than 6 centimeters above the GE junction, excuse me, and anywhere between 1 to 1.5 centimeters on the stomach. They all received an anterior Dor Fundoplication, and if the symptoms recurred post-op, they were considered a treatment failure. So here's the success rate over time of these patients who underwent either pneumatic dilation or laparoscopic Heller myotomy. And we see that, and this is per protocol, so this includes the 13 patients who were initially performed with the old protocol. And we see that, that there really is no difference, at least in 2 years, between the success rate in patients who underwent pneumatic dilation and those that went laparoscopic Heller myotomy. And then when they just take out those 13 patients, those initial 13 patients, again, still we see that at 2 years there isn't a difference between the success rates. So here are the rate of success at 1 year and 2 years between the pneumatic dilation and the lap Heller myotomy. Again, no statistically significant difference. The end LES pressure from the procedures between the pneumatic dilation and lap Heller myotomy, there's no statistically significant difference. And then the esophageal emptying study, basically where they insert a column of barium into the esophagus, and after a certain amount of time, they will measure the column of barium that's remaining within the esophagus. And again, there's no statistically significant difference between either pneumatic dilation or laparoscopic Heller myotomy. The perforation rate, if you look at pneumatic dilation as a whole within this study, it was 7.4%. And again, the other studies describe anywhere between 1 to 3% perforation rate. And then with the intention to treat, or actually this should be the modified intention to treat, they still had 4 perforations in these patients for a 4.2% perforation rate. The laparoscopic halar myotomy, they describe a mucosal tear in 13 or 12% of these patients. However, again, this is I don't know if it's truly a complication of the procedure, because we know that with a myotomy there is a risk of causing a mucosal tear, and the treatment for this is usually an anterior Dor Fundoplication to cover up that hole, which again was performed in all of the patients, in all 106. And then they had a 1% conversion rate. So when they looked at other factors such as abnormal acid exposure and esophagitis, there was no difference between the pneumatic dilation and the lap heller. So at 2-year follow-up, they can say, actually, if you read it, they will, since they're predominantly endoscopists, they write that the laparoscopic halar myotomy is not superior to pneumatic dilation. That's their conclusion. However, the truth is that at least in this study, there was no difference. There's no difference between pneumatic dilation and laparoscopic halar myotomy. However, there was a high perforation rate within those patients who underwent the pneumatic dilation. It's possible that with the myotomy on the stomach being anywhere between 1 to 1.5 centimeters, that this may have been an inadequate myotomy, and the 5-year results are still pending. So still, we have no answer between what's better to do. So when we look at future treatments for achalasia, this basically is, I believe, Covidion's, the laparoendoscopic single-site surgery. They were able to perform halar myotomies in patients and compare them to laparoscopic halar myotomies. And they found that at least when you compare both operative techniques, the less halar did take slightly longer to perform at 117 minutes compared to 93 minutes for the lap halar myotomy. 16% of the patients required an additional port to retract the liver. However, there were no conversions. And this is just and this is not going to work. All right. Excuse me, let me see. For Dr. Myers, I did come before, checked it, made sure it worked. It worked. But apparently now it's not working. So this is just demonstrating the actual appliance, the single port, how it's placed through a single incision, single periumbilical incision. And then also what's required are special instruments to be able to perform procedures through this. This was actually a lap chole, but and then at the end of the procedure.
So here it is.
And then that's all that remains, just one small single incision. Let me see. And then this started off in Japan, and now some people have performed it here, and it's referred to as the POEM, which is almost almost similar to Note's procedure, but this is the per-oral endoscopic myotomy. And then here, this one is also decided not to work. And here, with endoscopy, they get approximately 6 centimeters above the GE junction. And then they inject submucosally some fluid to start dissecting the submucosa from the muscle layers. Once they feel they have adequate space, they use a cautery to actually make a incision within the submucosa. They then place with balloon dilation. They further separate the submucosa from the muscle layers, or the mucosa from the muscle layers. And they'll continue with this down to approximately 2 centimeters beyond the GE junction on the stomach. They're able to insert the endoscope in through this submucosal tunnel, and then up to where they start seeing the muscle fibers. And so here they are. Once they've gone 2 centimeters below the GE junction, they have visualization of the muscle fibers. They'll start performing the myotomy. And then to close, let me see, what are they still doing? Oh, they're still dilating right there. And then here they're cauterizing the muscles, performing the myotomy. Yeah. And let's see, we'll get to, at the end, once they've completed the myotomy, they basically close the mucosal defect with a couple of endoscopic clips. Usually the patient's kept MPO for a couple of days, and then a swallow study is performed. They're fairly quickly advanced on their diet, and they're most of the time discharged by post-op day 2. So again, this has been performed predominantly in Japan. However, there is interest in bringing it over here, and this group has they've been able to describe the procedure.
No data on that?
No, yeah, there's data from Japan, and it's pretty good. It's comparable to lap Heller. No. Okay. Adelot says no. All right, so we've gone over the history of achalasia, the pathophysiology and etiology, as well as presentation, the diagnostic modalities, and again describe the new diagnostic modality, esophageal topography, and then the various treatments, predominantly with the 2 main ones being pneumatic dilation and laparoscopic Heller myotomy for achalasia. Also 2 possible procedures, the LESS Heller myotomy, as well as the POEM procedure. Okay. With that, I welcome any questions. Thank you.
Dr. Myers, start your POEM.
POEM.
Dr. Adelot.
That was great. What a good review. Very exhaustive. The one comment about that notes procedure, whatever they call it now. So when they first started thinking this up, they started doing it on pigs. Like, I don't know if that video is actually from a pig.
That was human.
Yeah. So they killed off a third of the pigs. Like, not like just perforated them, but like pig dead. And it really raised the question, like, whenever I started hearing this being presented, it raised the question sort of in general about people trying to improve upon laparoscopic surgery. Like, I just saw something in General Surgery News on my way over here that they're going to start doing notes laparoscopic cholecystectomy. I mean, for what? To improve on the go home today plan? I mean, I don't get it. So, but like in a more general sense, lap myotomy, this is really a problem of referral in my mind. Like, every study that's done says, well, myotomy is about 90%, works pretty good. And every study except for the Euros, who did this last one published in the journal, is 60, 70%, sorry. And redo. Except for these guys say 90%, roughly the same.
Dilatation.
Well, dilatation.
Yes.
We're not even talking about Botox anymore. That kind of came and went.
Right.
But what I don't get is in this laparoscopic. I mean, in the New England Journal article, did they use two different outcome measures for both? You described two in your slide. Like the surgery was symptom relief, and the dilation was something else. That's one question I had for you. And the other was, of the people who had the mucosal tears, it seems like lots of times the standard repair to that is repair the mucosa with some chromic or something, then do the Dor. Of the people who had mucosal tears, did any of them had big bad problems from that? Drain placements, open abdomen forever, the thoracotomy? But the people with perforations from their pneumatic dilatation, what did they get? Did that equal, just watch weight, or did that equal, full half of those thoracotomy and big chest tubes and whatnot?
So those are actually good questions, and I'll answer the last one first. So of the patients who underwent pneumatic dilation and had perforation, half of them ended up requiring a surgery for repair. The other half were managed non-operatively, just NPO, IV antibiotics, stayed in the hospital for several days. Of the patients who underwent laparoscopic myotomy and had the mucosal tear, it was, again, repaired by chromic, just like you described, and then the Dor Fundoplication. And there was no difference in those patients as far as between those that had mucosal tear and those that did not have mucosal tear. There was no difference between length of hospital stay, between symptomatic relief, or GERD, or anything else. There was no difference between any of those patients.
So again, it begs the question, like, why? What do you think is the limit of why surgeons don't see more of these? Why even do pneumatic dilatation? I just don't understand it. It seems like if I had it, you do multiple pneumatic dilatations on me. Now when it's time for this guy to go do my Heller, it's going to be much more difficult for him. What do you think the barrier to surgeon referral is?
Well, it has to do with the way we do get these patients. And that's a patient goes to their primary physician complaining of dysphagia. And the primary physician sends them to the endoscopist, to the gastroenterologist. And it is there where they basically end up determining the course of this patient's care, whether the patient is going to be pneumatic dilation, followed for a couple of years with multiple dilations. There are a couple of the long-term studies that were greater than 15 years, where some of these patients received greater than 10 series of pneumatic dilation, with a couple of them receiving like 16.
It's the same phenomenon we saw with GERD. They would get a new drug, and probably were getting paid per patient that they enrolled in the studies. And so by the time we thought the results were bad, we would get them. They came up with another drug. They're getting paid to do the endoscopy.
However, the recent studies on long-term outcomes of pneumatic dilation do list those three factors that are associated with risk of failure. And those are patients that are young, younger than 40, patients with a high LES pressure, and then patients who, and then again, this goes towards the high LES pressure. If they have incomplete obliteration of the balloon waist at dilation. And even here in our facility, we have received a couple of patients who were young, who just went to go see the GI. They confirmed achalasia with the barium swallow and did not even do dilatation, just sent them automatically to Dr. Van Sickle. So we are starting to see some of that.
Okay, so one comment, two questions. First, I hope everyone was listening to what you do when you have a perforation during a Heller myotomy, because while the perforation rate in these series is, 2, 3, 4%, perforation rate on your boards is 100%. Okay, so you will perforate the esophagus during your Heller myotomy on the boards, and you need to know how to deal with it. Two questions. So how long are you going to do your myotomy? You have to do one later today. What myotomy are you going to do?
I'll go, and this is due more to what's more commonly described, like 4 to 6 centimeters on the esophagus, and then 2 centimeters on the stomach.
It's hard to tell, right?
Yeah.
And this is not an anatomic sphincter, it's a physiologic, and I'm sure there's that great variability, and so that's why people come up. We know most people it's 4 centimeters, but we've seen it as high as 6. So that's what we're trying to tell.
Right.
Well, there are some places that actually, and this is predominantly in Italy, that perform manometry with all their lap pellets. And they do so because they want to find the exact location of the LES, and they want to ensure that they've relieved all of that high pressure zone of the LES. And so with all of their surgeries, and they describe more than 300 patients that they do manometry. Now, a lot of other surgeons, especially when they presented this in thoracic symposiums, that a lot of other surgeons don't agree with that, and they do not do the manometry.
Okay, last question. When I was studying for my boards a long time ago, the term we were taught to recognize is vigorous achalasia, which is diagnosed by tertiary waves on the manometry. So a completely dysfunctional esophagus. And those were not candidates for anything other than surgery because they're going to fail dilatation, they're going to fail anything else. And so that was one of the abstract questions, the written board questions, and the oral board questions. If they tell you tertiary waves, you go straight to surgery. I was surprised in the entire talk you never mentioned that term. Is that not really a concern anymore?
It is, and there are classic manometry results of patients with vigorous achalasia, and as well as the esophageal topography, and they all involve this the high pressure LES with just increased strong esophageal contractions, distal esophageal contractions that all occur at once. And at least with topography, that's really helped because it helps differentiate those patients from diffuse esophageal spasm, because those were the patients that were continuously, they were difficult to differentiate between them. But that just added additional time on my presentation, and so I left out vigorous achalasia.
One of the other differential diagnoses that you should come up with, dysphagia and undigested food, vomiting of undigested food, is the Zenkers. If you don't mention it, we'll take you down that path. The other, I think Dr. Van Sickle, if he were here, you didn't mention doing a post-procedure EGD underwater. Dr. Peterson, is that what you do?
Yeah, exactly. So you talked about two things to do with that EGD. One, you're testing for a leak, but the second part of that is using the laparoscope looking at the myotomy with the endoscope passing in, you can see the bulging of the mucosa, but that light reflection can also, you can see if there are any fibers that have not been cut by your myotomy coming down towards the stomach. So that's very beneficial to do, and it makes it much easier. You can know you just slide right through. My one question, and you kind of mentioned when we talked prior to this with that with the manometry, is I just wonder how effective that will be in a surgical setting when the patient's been giving muscle relaxants and whatnot. I'm not sure how that will play a role. Obviously, they've done it on 300 patients, so they have some feeling, but I don't know that that's going to be as effective. I wonder.
Yeah, one of the things they say is that patients cannot receive parasympathetic mimetics, botanical, during the procedure. And the question was asked, how often does manometry change the procedure? And they really weren't able to give a definite answer on that, other than say, well, yes, sometimes it does.
Classically, that perforation that you talked about is right as you're coming onto the stomach. But right there's 3 layers of muscle. There's an oblique layer besides the circular and longitudinal, and that's when you go in. It's like with a ramp stretch, kind of over myotomy. As soon as you come onto the stomach, that's classically where you get in.
It's the most difficult because there's all sorts of techniques, hooks and all this stuff. But right, exactly. I take the harmonic and put the inactive blade down and go up. That's super easy to cut up, but you can't reverse the harmonic down, so you got to use the hook or scissors or something. And so you're going to either do this, and that's exactly right.
I think that's about it. The last thing they talked about exclusion criteria. When you read a paper, they should tell you how many patients were excluded. Did they in that paper? They enrolled 214. If they excluded 214, we're the suspect. Any other questions? All right, thank you very much.